Hi, folks. This is Brenna Rabel from Battelle, and we are going to go ahead and get started. So good afternoon, everyone, and thank you for joining my colleagues and I for today's presentation on understanding clinical quality measures and how CMS is modernizing its approach to digital measurement. My name is Brenna Rabel. I am a measure developer and the current stakeholder engagement lead on the Measures Management System contract for Battelle. And I am joined by the CMS lead for the Measures Management System, Kim Rawlings, as well as Shanna Hartman and Debbie Krause, also from CMS. So this webinar is part of an ongoing effort by CMS and Battelle in our role as the Measures Manager to engage the public and key stakeholders in quality measurement topics. And that's an effort that also includes bi-monthly info sessions, a series of newsletters and bulletins, along with special announcement emails and routine updates to the Measures Management System website. So if you're new to the series, welcome. We hope to provide you with some insights into our approach to quality measurement, as well as to some resources on how you can connect with us and get more involved in this work. And if you've been with us before, then welcome back. We look forward to expanding on previous topics and talking to you about digital measures. So before we jump into the presentation, I do want to cover just a handful of housekeeping items. The first is that today's session is being recorded. Second, this presentation is being offered in a broadcast-only format, so that means that you won't be able to unmute your line. That said, we will have an opportunity for Q&A at the end of the call. So at that point or throughout the presentation, you can enter your questions into the Q&A feature in WebEx, and we will log those to respond to them later. Third, you're about to notice a poll popping up on your screen. Please do take a few minutes during the webinar to complete that. It really does help us plan future webinars and outreach activities based on who is joining these calls. And then finally, the most common question that we get is, can I get a copy of the slides? And yes, you can. They have been posted to the MMS website for your reference, and Martin will send that out via the chat feature during this call as well if you want to get a link to those. So today I'm just going to be starting with a quick overview of the Measures Management System and then get into a quick primer on eCQMs and other digital measures. Then Kim is going to talk with you about CMS's current thinking around digital quality measurement before turning it over to Shanna and Debbie to talk a little bit more about FHIR. So looking forward to that. All right. So who is Battelle and why are we leading this presentation with CMS? So as I mentioned before, we are the Measures Manager. CMS established the Measures Management System as a way to help standardize the process for developing, implementing, and maintaining quality measures. And it's good to note here that there is a difference between quality measures, quality improvement, and quality assurance. And today we really are focusing on the work that CMS is doing around clinical quality measures specifically. There are a couple of key components to the Measures Management System, as you can see from the graphic here on this slide, which is, I think, appropriately complex for how complex the team is. But I think the most outward-facing things that most people need to be aware of is that we create a lot of tools to assist in the development of CQM. So things like the CMS Measures Inventory, the Blueprint, and the MMS website all fall under our purview. And then the second key component is what we're doing right now, which is stakeholder engagement. So we really strive to engage a wide variety of stakeholders, including patients, clinicians, specialty societies, patient advocacy groups, and then, of course, measure developers on how to get involved in the eCQM and CQM processes. And so now I just want to set the stage a little bit for what Kim is ultimately going to be talking about around digital quality measures. So as I'm sure most of you are aware, the purpose of a clinical quality measure is to promote good decisions that lead to good outcomes. And we define a good decision as one that makes it more likely that the user of the measure will experience a good result. And at the same time, it also makes it less likely that the user will experience an adverse event or a result that wasn't foreseen or not understood. And I wanted to highlight the key terms here. So a CQM is about the probability or the likelihood of experiencing a good result. It's not a guarantee of experiencing a good result. So how does the use of a CQM as a tool actually affect decision making? And how does quality actually improve through the use of quality measures? You know, and maybe an oversimplification, there are essentially two pathways by which that happens, and that is selection and change. So selection is patient-driven. It involves moving populations of patients from low-performing clinicians to high-performing clinicians. And then if you do that, the average outcomes improve. And then on the change side, that really comes from provider behavior change. It's about individual clinicians moving from lower performing to higher performing, and to the degree that that happens, the overall performance improves. So again, it all comes back to making good decisions. So quality measures are most commonly expressed as rates, you know, proportions or percentages. And measure specifications typically include, although are not limited to, the components that are listed here. So, you know, we have the target population, a subset of which is the denominator. So that's really the group of people to whom the measure actually applies, or the people that are being evaluated. And then the numerator refers to really the measure focus, so the identification of those from the target population who achieve the specific measure focus. And then there are exclusion criteria and exceptions, and those are basically any concepts, conditions, treatments that should be excluded from the measurement for one reason or another. And we'll get into a specific example on this next slide here. So using the specific example of cataracts, 20, 40, or better visual acuity within 90 days following cataract surgery, you know, this is just one sort of clear-cut example of an outcome measure. So looking at of all cataract surgeries for patients 18 or older, the percentage of which had a best corrected visual acuity score of 20/40 or better. And of course, that measure excludes certain populations, people with significant ocular conditions that would actually impact the visual outcome of the surgery. So to show that mathematically, what you have up here is that numerator statement, right? So cataract surgeries with best corrected visual acuity of 20/40 or better. And then underneath you have your denominator, which is all cataract surgeries for patients 18 years and older, minus those exclusions. So cataract surgeries in patients with significant ocular conditions that might impact the visual outcome of that surgery. And that results in the measure score, which is that proportion. And keep that example in mind, because I am going to reference it in a little while. But there is a lot more nuance to a measure than just its main components of denominator, exclusion, and numerator. So in addition to the discrete data elements that make up each of these components, which we'll talk about more in a few minutes, we also need to understand how the data source for a given measure impacts what we can measure and how generalizable it is. So in this case, a data source refers to the type of data used to calculate the measure. And this information is here on the slide for your perusal, but for the sake of brevity, I'm just going to talk through a few of them. So administrative data, this is typically information that's collected for billing purposes. So one great feature of this, something like a claims data, is that it's stored in standardized format using ICD-10 codes, and it makes it really straightforward to extract and report from measurement. And then, of course, there's electronic clinical data, so that includes something like an EHR, but can also include other patient-level information that can be extracted in a format that can be used in a measure. So things like data from personal health devices or other electronic sources that could be uploaded to an EHR. And then I also really want to make sure I highlight registries. So registries are collections of information often used to collect disease-specific data for public health or quality improvement purposes, things like an immunization registry. And CMS uses data from qualified clinical data registries and qualified registries in the QPP program. So now I just want to transition a bit to eCQMs, or electronic clinical quality measures. You may recall from the previous slide on data sources that some measures are derived from the electronic health record or EHR data. So eCQMs are among those measures. However, they are not considered electronic because they're derived from electronic data. Rather, they get their name because their specifications are designed to be machine readable. So taking a step back, clinical quality measures have historically been chart-based, meaning that healthcare organizations that report on these measures had to designate a staff member to manually extract information from patient medical records and then submit that information to CMS. And as you can imagine, this process is time-consuming and susceptible to inconsistencies in reporting across different abstractors, as well as things like human error. So eCQMs make it so that manual abstraction is unnecessary, and rather eCQM specifications are programmed to extract the required information and submit it in a readable format to CMS. So in addition to saving time and resources, eCQMs are associated with lots of other advantages, including better consistency and uniformity of the data within and across healthcare entities, and an overall reduction in error. And in order to generate and evaluate electronic specifications, measure developers use a number of different tools. So there's the measure authoring tool, or the MAT, which is a web-based tool that allows measure developers to input measure details, so things like the target population, data elements, and the logic that connects those data elements together, and export that information into a series of data files, some of which are machine readable and others that are human readable. And those outputs altogether are referred to as the measure specifications. So the Value Set Authority Center, or the VSAC, is the authoritative source of value sets. Value sets are essentially lists of codes that, when put together, define a given clinical concept. So for example, using that cataract surgery measure example that we talked about, consider the concept of 20/40 vision or better. To capture that information electronically, the measure developer would need to specify the codes associated with that clinical concept. And as it turns out, there are a number of different codes associated with a visual acuity exam. So in the VSAC, all the codes related to that concept can be grouped together into one value set, which the measure authoring tool can readily import to use to define that data element in the measure specification. And then the body tool is not something that most non-measure developers are familiar with, but it's a really important resource in eCQM development. It's basically used to evaluate the underlying logic of the eCQM specifications, and it's a pretty crucial step in making sure that the measures that end up used in CMS programs are valid. And as I mentioned in talking about the measure authoring tool, eCQM specifications are actually a compilation of several file types. So on this slide, we're showing how some of the denominator exclusions are specified for that measure. So on the left, which is the human readable language, it shows us which types of conditions are excluded from the measure denominator. And then on the XML file on the right, you can see how this information has been translated into an electronic file. So for the exclusion for patients with a diagnosis of optic neuritis, which you can see circled on the left in very tiny writing, the XML file on the right shows how that gets translated using the value set identifier from the VSAC in a machine readable format. And the beauty of this is that the MAT does it for us. Now, eCQMs are just a subset of a larger category of measures known as digital measures, or DQMs. We spend a lot of time talking about eCQMs because they are by far the most recognizable type of digital measure used in CMS programs. However, recent years have shown an increased interest in other types of digital measures as well. So like eCQMs, all digital measures must originate from an electronic source of health information, and they need to be specified in a format that allows them to be transmitted electronically. Historically, this has largely been limited to electronic claims or EHR systems, but digital measures can be derived from any type of electronic data source, including clinical registries, health information exchanges, case management systems, wearable devices, patient portals, and so on. And the advantage of these measures is an increased pool of data types from which to pull data elements, and as such, an increase in the types and complexity of measures that can be used in clinical quality programs. So their use overall really allows for more efficient capture, retrieval, and sharing of patient data, and therefore enables the creation of measures that promote coordinated care, improved health outcomes, lower costs, and greater transparency. But because of their unique composition, eCQMs and other digital measures are associated with a number of key considerations and potential challenges. And these include the availability and accuracy of standardized data elements, specialized testing requirements, and challenges associated with interoperability. So I'll just take a few minutes in the next 3 slides to delve in each of these a little bit more. So of course, patient health information is stored in the EHR, and as such, EHR data is a rich source of information about patient health status and treatment. But that said, information is not collected specifically for the purpose of quality measurement. So sometimes the data are stored in a format that works super well for the delivery of patient care, but causes some headaches for measurement. So for example, some critical information might appear in a free text field. So for example, something like physician progress notes or nursing notes that are easy to find in a manual review, but are difficult, if not impossible, to extract electronically. In other cases, information that's stored in a structured field, like a drop-down list, may not be coded on the back end to a standard terminology. And those are the codes that we really need to use to create value sets. So in these instances, health IT professionals have to map those data elements to the appropriate codes in order to comply with reporting requirements, and that can be really costly and time-consuming. And EHR systems also vary considerably from site to site, and it can be difficult for measure developers to account for all of the areas of the health record that important information may be stored in. So knowing about these challenges, measure developers engage a variety of healthcare entities and experts to provide feedback and to participate in measure testing to mitigate these issues. So part of that is very robust feasibility testing. And in eCQM specifications, developers often think about including really broad definitions for key data elements to ensure that the pertinent information can be collected from a variety of EHRs without major inaccuracies or missing data. And that brings me to the specialized testing requirements for eCQMs and other digital measures. So obviously that testing includes some of the feasibility work that I mentioned on the last slide. So for eCQMs, that includes the use of a feasibility scorecard, which allows measure developers to get down to the data element level to evaluate the likelihood that most healthcare organizations would be able to report on that measure if it's included in a program. eCQMs also have specific requirements for assessing validity. So in addition to the body testing that I mentioned earlier, broader measure level validity testing helps us understand whether the measures are actually getting at the issue that they purport to measure. And one of the important features of eCQM validity testing is to compare eCQM data against manually abstracted data. So measures undergo testing involving at least 3 different test sites, and at each one, trained abstractors will pull information from the health record based on the measure specifications. And then the site would also run the eCQM specifications, compare the results with the measure developer. The measure developer then compares the findings from both data sets. And if the data largely matches, then we consider that eCQM to be valid. And if there are major discrepancies between the 2 data sets, then measure developers evaluate the sources of those discrepancies and try to rework the measure to improve it. And naturally, these requirements can be difficult and time-consuming, both for measure developers and for the participating test sites. But these efforts really are crucial in determining whether a given eCQM is valid and, by extension, viable for use in a program. Finally, it probably goes without saying that healthcare is complex, and CMS and its measure developers are working to develop measures that capture that complexity. And one facet of that complexity pertains to the issue of interoperability, which really just refers to the extent to which healthcare data systems can talk to each other. So consider asthma treatment. A patient might first approach their primary care provider about their symptoms before being referred to a specialist for diagnostic testing. If that patient has a severe asthma attack, they might find themselves in an emergency department for treatment. And then upon leaving the emergency department, that patient might be referred back to their physician for changes to their medications. So tracking care that's coordinated across providers is really challenging, and it really relies on the availability of interoperable EHR systems. So in large healthcare systems, this might be the case, where all the information from all of those different patient encounters gets stored in the same EHR system, making it much easier to follow that patient's care across the continuum. But how do you track care from one provider to another when those providers don't belong to the same EHR system? It's a goal of some digital measures to have a linking capability. So in other words, making sure information from each data source can be tied to the same patient or the same provider, depending on the level of analysis. And then also FHIR is another pathway toward improved interoperability, but I'm going to let Kim and Shadow talk about that as they walk you through CMS's digital measurement strategy. And with that, I am going to pass the ball to Kim.
Thank you, Brenna, for providing some of that background. And there's a ton of material to cover, so I'm just going to go ahead and jump right in. So hopefully you all are familiar with Meaningful Measures. It was an initiative started in 2017 as a part of the Patients Over Paperwork initiative, and it was really meant to help reduce reporting burden for clinicians by taking a harder look at our quality measures and really trying to ensure that we were only using the highest value measures possible. So now it's 3 years later, and we find ourselves in a time of real refinement and review as we move towards Meaningful Measures 2.0. Here you can see that the key themes we're working from are kind of our draft version where we're still taking comments on these, but really trying to refine this initiative to support us in uniting strategic efforts to adopt measures that are most critical to providing high-quality care, reducing the burden of quality measure reporting, and driving better patient outcomes at lower cost. And so to achieve this, we really need to make sure that we're creating a more rapid feedback loop to providers on their performance so they have that information and can use it. We also want to make sure that we're considering, like I said before, collecting and reporting burden. And so we're going to work to achieve that by accelerating the move to fully electronic measures, making sure that we are promoting the use of all payer data wherever possible, increasing alignment across CMS and federal programs, as well as through private payers. And last but not least, really prioritizing composite measures that reflect the domain so that we're having a composite healthcare infection measure rather than having 5 or 6 or more separate infection measures. Also important to this effort is, of course, including the voice of the patient, and that's really critical. We want to make sure that we're staying patient-centered in our quality work through a continuing prioritization of patient-reported outcomes in our programs, as well as making sure that their voice is continually heard throughout the measure development process itself as well. It is also important that we modernize our quality programs and advance innovative payment structures as we look ahead. As such, we really need to make sure that we are developing and using measures that will help us achieve that goal. And so part of the modernization of our measures and our program is the journey from paper to digital data sources. And so when we started our quality programs, we used mostly traditional measures, traditional CQMs that were manually chart abstracted, and then with the increased usage of EHRs came the creation and adoption of eCQMs. But we were still using some chart abstracted measures at that point. And while the development and implementation of eCQMs has come a long way, there are still challenges to be addressed, and eCQMs may not currently be feasible in every situation and every setting where we want to measure quality. And so we need to think more broadly and focus on the quickest, easiest ways quality data can be collected and used, and that way is digitally. Now, we're working towards having all of our measures be digital quality measures, which Brenna described earlier, to really promote a continuous learning and improvement system, incorporate more clinically relevant data, reduce burden, and make quality information more actionable at the point of care. The need for interoperability, of course, has not diminished. If anything, it's grown. The current COVID-19 pandemic really demonstrates that need, and that need for urgent, robust, timely data, which is available at each point of care, wherever that may be. So how do these key themes in our movement from traditional chart abstracted measures to digital claims or EHR source measures work in our program? Well, first I can say that the activities and the guiding principles that I'm sharing thus far have really been priority for CMS for years. But I think with the new key themes that we're considering for Meaningful Measures 2.0 and the resources that we recently developed, which I'm going to get into a little bit later, we've really created more momentum and are setting some new exciting goals for ourselves. But quickly, I want to touch on the progress that we've made thus far on the quality inpatient, quality inpatient reporting program, because I think it's a great example. So looking at fiscal year 2017 payment determination, FHIR had 63 measures, of which 15 were chart-obstructed measures and 2 were structural measures. So looking towards the fiscal year 2022 payment determination, we've decreased to only 23 measures. That's an almost 70% reduction in the total number of measures. And we also went and reduced those 15 chart-based measures to only 2 and eliminated all of the structural measures. We also eliminated a lot of redundant measures and increased the percentage of claim-based and eCQMs in the program measure set. And so this is the direction we need to continue to go in order to achieve acceleration of fully electronic measure sets, alignment across the entire quality measurement enterprise, prioritization of composite measures that reflect the domain, and all of the other goals that I've outlined. To get the rapid feedback and the ability to leverage advanced analytics to inform care planning and facilitate care coordination, we need to promote a fully interoperable and digital measures with the goal of having 100% of quality measures being digital by 2030. The evolution of quality measurement needs to continue. It needs to happen quickly. And so how do we do that? How do we strive to make a progressive goal possible? Well, this is a very aggressive goal, and we are still trying to figure that out. I think that the goal is that by, if we aim for 2030, we might not meet 2030, but at least we're headed in that direction, and we're headed there with a lot of momentum and a lot of push kind of behind us to make fast progress. And so first, we really need to make sure that we finalize and communicate that plan. So having a formal kind of digital measure strategy, of which a lot of the things I'm talking about today would be a part of that. We also need to make sure that we're advancing our electronic sources and making innovations in the way we use electronic data in quality measurement. So to highlight a few of these, as examples, we need to develop more APIs for quality measure data submission. APIs can help practices improve the usability of EHRs with the assistance of some third-party software to really consolidate all of that health information in one place. We can also look into the prototype of the use of the FHIR standard for quality measurement, which Chance will talk about a little bit later. And this will really eliminate the need to learn and maintain multiple standards. Like I mentioned before, we're still actively thinking through this plan on how we would go about achieving this 2030 goal and how we can continue to modernize and digitize our quality measures and programs. So here are some more steps that we're considering, and again, we would really appreciate any feedback or comments that you have either during this call or to some resources I'm going to describe a little bit later. So first, kind of on the list to consider is to leverage new and advanced technology to develop new approaches to quality measurement improvement. Such technology could be used to mine data from multiple sources to really capture information about the patient journey across the entire care continuum. Doing so would really pave the way for the use of predictive modeling and machine learning to enable CMS to predict outcomes for its beneficiaries and and identify areas where quality improvement initiatives and measures may be beneficial. Also, as Brenna mentioned earlier, testing for eCQMs and other digital measures can be costly and time-consuming. It can be a really challenging process. And so I really want to emphasize the explore part of this sentence here, but we recognize the challenge. And to address the issue, CMS is really exploring the possibility of creating novel electronic test beds to speed up and streamline digital measure development. And doing so would not only reduce the overall cost of developing measures, but it could also allow for more thorough evaluation of scientific acceptability of measures before they're used across our programs. Finally, we're also continuing to prioritize efforts to promote interoperability. Part of this effort includes work to prevent data blocking, support data aggregation and electronic prior authorization through appropriate legislation for comprehensive patient information. Improved interoperability would really enable us to increase the accuracy of patient information, increase improvements in care coordination, as well as comprehensive reporting to CMS. It also enables the creation of more nuanced quality measures that address care coordination and long-term outcomes. Again, feel free to contact us. Your feedback and thoughts will be helpful to us as we consider if and how to take some of these steps. Now I wanted to shift slightly and talk a little bit more about some of the work that has been done and that we continue to build on in order to support our movement forward towards digital measurement and other modernization efforts. So as part of the eCQM strategy project, CMS completed an environmental scan, a 2-day stakeholder listening session, and 17 site visits to really try and better understand the primary issues as well as recommendations for improvement in the use of eCQMs in CMS quality programs. Stakeholders were generous with their time and really shared their experiences with eCQM, specifically with the complexity and burden of eCQM development, implementation, data capture, and reporting. And most importantly, share those ideas and recommendations for improvement. And so there were 6 key issues and themes that kind of came from those discussions: alignment, value, development process, the implementation and reporting process, the process of EHR certification, as well as communication, education, and outreach, and the need for additional engagement with stakeholders. So I don't want to go into all of these in depth here, but the outcomes report was just published in August of 2020, and I really encourage everyone to take a look. It's only a 25-page document, so it's really short and an easy-to-read resource, and I encourage everyone to check out and pass along to colleagues. Like I said, a true representation, I think, of speaking with a lot of stakeholders, having listening sessions, doing site visits, etc. I also want to mention the eCQI Resource Center, and I'll show a slide of the actual website, I think, a little bit later. But on that site is the Measures Collaboration Workspace, or the MC Workspace. And it's a really exciting resource that can be used throughout the measure lifecycle. There are 4 main modules on it. First, there is the eCQM Concepts module, where you can suggest a concept for an eCQM. Stakeholders have the option to submit an eCQM concept for feedback from other stakeholders and to ultimately submit that eCQM concept to CMS for review. There's also the new eCQM Clinical Workflow module, which provides access to a shared development workspace. There, stakeholders can provide early comments, clinical workflow concerns, and guidance during the development lifecycle of evolving eCQMs. Lessons learned from previous measure development efforts can really help measure developers address implementation-specific issues that arise during development. eCQM developers themselves can go into the Workspace eCQM test results module, which allows users to participate in eCQM testing by providing proposed eCQMs for testing, submitting test results using eCQM data element, feasibility template, and viewing test results. The last module is the eCQM data element repository. Like has been mentioned, the measure development and implementation process is neither quick nor easy. And while there are many tools and resources supporting the development of measures, I want to quickly focus on two here. The first one I want to mention is the eCQM data element repository module in the MC Workspace, and it provides all the data elements associated with published and tested eCQMs for use in CMS quality reporting programs, as well as the definitions and clinical focus for each data element. So an end user can sort the information by eligible hospital or critical access hospital eCQM, eligible professional, eligible clinician, eCQM, data element, eCQM, QMD attribute, or QMD category, and QDM data type. The eCQM, the module allows users to quickly benefit from all of the data elements, QDM attributes, QDM categories, and QDM data types associated with an eCQM, and which eCQMs share these items, eliminating the need to access multiple documents for this information. So a really great resource there. You can also look towards CMIT, or the CMS Measures Inventory tool. It has an environmental scan feature within it. So CMIT itself is a repository of CMS measures actively implemented or finalized in CMS programs, but also those proposed or removed. So for many measures, when you look in the measure detail of an implemented or finalized measure, you can find a list of up to 30 peer-reviewed articles from PubMed, PubMed Central, and CINAHL related to the measure, based on a sophisticated taxonomy and natural language processing. It can be really helpful when conceptualizing similar measures to look at that for existing measures, or you can look at it just to learn about an existing measure as well. I also wanted to mention and highlight some work being done through a CMS contract with the National Quality Forum on EHR Data Quality. In the summer of 2019, the National Quality Forum convened a multi-stakeholder technical expert panel to identify best practices addressing EHR data quality issues impacting the development, endorsement, and implementation of healthcare performance measures that use EHR data, and then subsequently to help develop recommendations to try and mitigate these challenges. So currently on their website, you can find an environmental scan, which really serves as a foundation to the overarching goal of this project by summarizing current literature about EHR data quality concerns, current practices addressing these issues, and key stakeholders' major findings on currently available information. Then around September 30th, a draft of the final recommendations report will be available online for public comment as well. And with that, I want to turn over to Shanna Hartman to talk a little bit about FHIR.
Thanks, Kim, and I'm going to briefly talk about Fast Healthcare Interoperability Resources, or FHIR, and what that is and how CMS is looking to use that for quality reporting. But as you know, there is much to learn about FHIR and a lot that we're doing at CMS to implement FHIR into our quality reporting program. So the good thing is I'll show you where you can find additional information on that, as well as past webinars and educational sessions on FHIR. So what is FHIR? It's a Health Level 7 or HL7 international standard for exchanging healthcare information electronically. It's the next generation exchange framework that's being adopted to advance interoperability. And this allows clinicians and organizations to share information in a standardized way, regardless of the way the local EHRs represent or store that data. There are several benefits of FHIR that we're looking at as it relates to quality reporting, such as reducing burden, aligning the CMS eCQM reporting with industry clinical data exchange framework, reducing implementation burden, and enabling automated data retrieval with the use of application programming interfaces or APIs. FHIR can simplify the data mapping. This would provide a single mapping to FHIR versus currently mapping to both the health quality measure format and quality reporting document architecture for reporting quality to CMS. It also improves alignment between eCQMs and clinical decision support, both using that common FHIR data model, and it promotes interoperability. The data exchange requirements for quality measurement would then be aligned with interoperability standards used in other healthcare exchange scenarios. So here is a high-level roadmap for FHIR quality reporting and reducing burden through that streamlined data exchange for eCQM quality reporting at CMS. So our end goal really is to have a centralized reporting system for CMS. So the sender would send data into a centralized receiving system through a FHIR-based API. That CMS system would then do the quality measure calculation and transfer that data through a FHIR API to the applicable quality reporting program, thus reducing burden for our quality reporting submitters. So in this timeline, it starts with standards development, which includes the current FHIR standards that are developed and are still, as we speak, being refined to support quality reporting, such as the implementation guides and the standards used for quality reporting. The eCQM conversion, so to date, for the past several months, probably at this point almost a year, we have been hand converting the QDM and CQL-based eCQMs that are currently in use today for CMS to a FHIR and CQL-based eCQM, and we have been using those for testing and for pilot purposes to conduct feasibility testing and test our translation to FHIR eCQMs. As well as eCQM conversion, we actually now have a measure authoring tool using FHIR in user acceptance testing. So we are now having measure developers that are contracted to CMS transition eCQMs in the measure authoring tool to FHIR for testing as well. And including in those testing and pilots have been the HL7 FHIR Connectathons, which this most recent one, we did test specifications out of the mat in FHIR, which is exciting. And we also did conduct a CMS FHIR pilot where we did test eCQMs hand converted to FHIR with Cerner and Epic and stood up a mock FHIR receiving system at CMS. So for tool configuration, as I mentioned, the measure authoring tool is currently in user acceptance testing, and we are working to get a beta release of that tool out for measure developers to transition measures to FHIR. And we are also working on a Bonnie testing tool for FHIR and Cypress FHIR development. We then would need to update the CMS receiving systems and develop FHIR APIs for that streamlined reporting. And then, as I mentioned, a centralized CMS quality submission solution for quality reporting to CMS. And here I am showing the eCQI Resource Center, which I hope you are familiar with. This is a picture of our FHIR page at the Resource Center, which you can find at eCQI.healthit.gov/FHIR. And on this tab here, where this red arrow is the About tab, where you can find information about FHIR, how we are looking to use the FHIR standards for quality reporting. There are other tabs on here that you can also find additional information on FHIR, and specifically want to call out the Education tab, which has all of our past educational sessions on FHIR. And on the main page of the eCQI Resource Center, you should also keep your eyes open for upcoming sessions that we'll be doing around FHIR, and additional webinars are also posted there for upcoming educational sessions. And I believe I will pass the presentation back over to Kim.
Thanks, Shannon. I really appreciate a lot of those details. And so we do want to get to your questions. I know there are several shortly, but I do just want to quickly run through a couple of resources. And I'll warn you, I am going to tease you with a few that will be coming out towards the end of the month. So just as a quick recap, I mentioned the CMS Measures Inventory tool, which is a searchable repository of measures used across all of our CMS quality programs, not just those that are actively in our programs, but also those that have been removed and are under development. We also have our eCQI Resource Center. Again, if you want to know anything at all about eCQMs, this is really your one-stop shop for all, not just education and resources to learn more, but also to really stay up to date. They host a lot of great different webinars and things as well. So really encourage everyone to check out that website. That should be your first stop after this meeting. So this is one of the teases, but we will be sending an email out to everyone that participated after a couple of weeks after this call. So you have a recording of the call that you can share with colleagues, as well as have all of these resources at your fingertips in live links as well. But one of the things that we will definitely be sharing and we're excited to be published at the end of the month, is our Quality Measures 101 document, which really describes why and how CMS invests in quality measures. And this is not specific to eCQM, so it really it's agnostic to the data source in that regard, but it really just takes a step back and talks about why are we doing this, why are they important, what are the standards that they're held to, etc. So very excited about this. The other thing you should check out after the eCQI Resource Center and CMED is our MMS website and the blueprint. A lot of great resources there as well as a list of ways to get involved and tips that are actively accepting nominations and public comment periods that are open, etc. So a great resource. And I do also want to mention that the blueprint, again, at the end of the month, is going to have a huge revision as we update for version 16. We're very excited to make the document more streamlined and accessible. If you are familiar with the blueprint, you'll know that it's about 400 pages long and very, it has a lot of complexities to it. We have streamlined it. We have made it smaller. We have made it more accessible, and it comes in at only 100 pages. So we're excited to debut that closer towards the end of the month. And again, when we send this email, the link to that will be in there as well. Oh, wrong direction. There we go. And then I also mentioned Meaningful Measures website. Again, great resource that talks about kind of our forward thinking there. And as soon as next week, we anticipate adding a new page that will talk all about our current thinking around Meaningful Measures 2.0 and how you can provide comments as we begin to finalize and refine Meaningful Measures in the next, as we continue the initiative. So with that, I want to turn it over to Brenna, who's going to give us some questions from the audience.
Thanks very much. And thank you all for your participation so far. We've got a great list of questions. And I will just say up front, if we don't get to your question, we are going to be sending out a summary email in a week or so. So we'll try to address anything that we don't get to in that message. So I will start off. Somebody asked, what role does the clinical quality language play in the development and use of eCQM? So that is a question that I can answer, but I will turn it over to Shanna and Debbie to add. But CQL is the authoring language that's used in the measure authoring tool. So it's intended to be human readable, but structured enough to enable the processing of electronic queries. And so I didn't talk about it just because of timing, but basically that's the language that's used when we're creating measures in the measure authoring tool. And you can find lots more information about CQL and all the other resources that I mentioned on the eCQI Resource Center, which is probably a good segue for me to let Debbie talk a little bit about that website really quickly and just provide a little more context around that for our audience.
Sure, thanks, Brenna. This is Debbie, and the eCQI Resource Center was created by CMS as a result of hearing from you all, our stakeholders, and their feedback about 5 or 6 years ago, which was you have a lot of good information, but it's scattered all over throughout many pages and many different websites. So we created the one-stop shop for all things related to eCQMs, which is the Resource Center. And on the Resource Center homepage, you'll see tabs and news bulletins about everything from all the different standards, the electronic specifications, which is the source of truth on the Resource Center for the eCQM specifications, to information about standards, about the quality data model, et cetera. And the biggest new addition is the Measure Collaborative Workspace, which you heard about earlier from the eCQM strategy project we did. Again, that workspace is a result of all the stakeholder feedback that we've received from across the country and with hundreds of stakeholders asking for a location where they could get data elements defined, give CMS feedback on what measures they would like to see created, comment on new measure workflows, comment on new measure data element feasibility, et cetera. So again, all of this is a response to our stakeholders and trying to make things more usable and better explained for you in relation to eCQMs.
Thanks so much, Debbie. That's great. Okay, let's see. We also got a specific question about whether or not a DQM can use a POCT glucose meter reading as a medical device. I will confess that I don't know specifics around that particular medical device, but would say that in general, yes, any medical, like personal medical device data could in theory serve as the basis for a quality measure if that information, you know, can be exported to something like an EHR for submission. You know, of course, all of the same normal criteria would apply, you know, looking at the target population, the likelihood of a positive impact of that measure. You know, you still have to be able to demonstrate measure validity and all of that. But I would say, in short and in theory, yes. But I do want to just check in with CMS to see if they have anything to add to that.
This is Debbie. So I would agree with what you've just said. The vendors will be able to test the measure results through certification or through use of the Cypress validation utility, which can be used after certification. But that CVU Plus does incorporate new measure updates every year, and we encourage submitters to test those results by using the CVU Plus. So that would also be able to accommodate data that's obtained and then sent to the EHR and used in the calculation of the measure.
Thanks for that, Debbie. All right, we probably have time for 1 or 2 more questions. Another person asked, what's the difference between a DQM and an eCQM, so a digital measure versus an electronic clinical quality measure? So again, I think I can probably take an initial stab, but I will turn it over to my colleagues at CMS for them to weigh in. But an eCQM is basically a subset of the larger category of digital measures. So eCQMs are specifically derived from EHR data. They involve machine-readable specifications, and they have very specific testing requirements, whereas digital measures are really any measure that's derived from an electronic data source, which can include but is not limited to EHR data. So that can include medical device data, patient portal data, registry data, even claims data if it's stored in electronic format. So the definition is a bit broader, but again, I'd like to turn it to CMS to weigh in and to add some contours to what I just described.
Thanks, Brenna. No, that's exactly right. eCQMs are a subset of digital measures. And, you know, I saw a couple of questions in there around where can I find more information or comment on this. You know, we are still kind of, I would say, I don't want to say refining, but we're still working, you know, the term kind of digital quality measure in this context is extremely new. And so we're still refining that definition, and I think you'll be seeing more of it in the coming year, whether it be in rules or in relation to Meaningful Measures 2.0 and just various avenues. And so if you have any further questions or comments or suggestions, you know, we definitely welcome them, but this is kind of a new term that we're defining here.
Thanks, Kim. And with that, we are at 3:58, so I think we probably should wrap, but we do have a lot of other fantastic questions, and I really want to, again, thank you for your participation today. We will get an email response, at least to maybe a summary response to some of those questions, because there were some common themes. And thank you again to my colleagues at Patel and at CMS for their work on the panel today. I'm sure that we've all appreciated your guidance and your expertise. So thanks, everyone.